And now, our last session, Big Data and Big Results. For that, we're joined by Wyatt Decker, the CEO of Mayo's Arizona campus. Dr. Decker is overseeing a big data initiative at Mayo. Researchers are studying health claims of more than 100 million people and records of 30 million patients in search of answers to tough medical questions. Dr. Decker is here to tell us about that and about how Mayo is using big data and other scientific advances in an effort to save money and benefit patients. Steve, Dr. Decker?
Thank you very much. Thank you. Thanks.
I'm back. I may take my tie off. I need to sit in a different chair. I need something different. Tina's back. I'm happy. So 109 million people in this research database that you're looking at, and so you're sort of the Wizard of Oz behind the screen and can see everything happening. What are you seeing?
Well, I'm not quite the Wizard of Oz, but big data is an important topic, and I would say a couple of things, just Steve, to kind of frame it. First is, big data is not in and of itself an answer to anything. There's always actually been huge amounts of data out there, and we're just now in the medical community figuring out how do we harness this. Don Berwick once said, weighing a pig does not make it fat. What does he mean by that? Well, the farmer knows that just weighing something isn't going to change it. So just measuring a system is a step in the right direction, but it isn't actually going to change anything. And we published an article in JAMA about 6 months ago looking at the application of huge data sets in surgical outcomes across the United States. And we found that just the application of a data set did not actually portend any change in surgical outcomes for the medical centers that adopted this shared database. So that's a note of caution. We also often hear garbage in, garbage out for big data, and that I would take issue with, because as you heard from Karen earlier a few minutes ago, we're actually getting better at mining chaotic or unreliable data than we used to be. And so
What's changed?
So the ability to actually look at, say, a doctor or a nurse's record, not just in an initially binary fashion, but actually, as you heard, natural language processing, or looking for unexpected patterns that I might have trouble identifying, but a large analytic system can find. So that's the power of analytics. So that's changing. And then the final piece I'd say is we have to maintain the engagement of our clinicians, of our patients, to say, okay, how do we interpret the data? What are the questions that we want to ask? And how do we make sure that we're getting at the root causes of improving healthcare? And one last comment, and I'll let you turn it back to our collaboration.
I want to go back to weighing the pigs.
Okay. So the other comment that I would make is that we're bringing together data from multiple medical centers to be able to actually share data. And this is what you alluded to initially. We've created a collaboration called Optum Health that is with United Healthcare's Optum Group and Optum Labs based in Cambridge, with collaboration from MIT and the Mayo Clinic. We now have 150 million lives of claims data. And with our clinical partners, which includes Mayo, Harvard Medical School, and about a half a dozen other medical centers, we have about 40 million clinical lives. These are de-identified, so you can't track them back to the actual people, but it allows us to look at trends over time. And that can be incredibly powerful. That's
40
correct.
million individuals.
40 million individuals with every detail of their clinical care.
It's a staggering number. Yeah. I do want to go back. You've raised so many interesting things, but I want to go back to the weighing the pigs issue seriously for a minute, because while weighing the pig may not make it less heavy or more heavy, and it's something, what behavioral science is telling us is interesting. If you weigh 2 pigs together, you weigh 3 pigs, and the pigs are looking at each other, it can in fact weigh behavior. This is what you saw. What you see in people getting energy data sent to them about what their neighbors are using. And you're seeing utilities using this as a service that if you let people in a community know what others are doing around you, that it's beginning to affect that individual's behavior. And I'm wondering, when you have that, even though it's not, right now you're telling us it's not going back to those individual data, but is there a way because we just had this fascinating conversation saying a lot of what we do to ourselves, we're just doing to ourselves because we think we're going to get bailed out at the last minute.
Right.
But if there was a way to connect the weighing the pig metaphor to seeing what someone else weighed or did, is that an opportunity that exists in the data world you're in?
Yes, yeah, actually, I think it is. So there's another side of that equation, which is the Hawthorne effect. So when we study something, we see that it often changes the behavior of the system that we're studying. And so that's perhaps partly what you're touching on. So, so the thinking is if we start looking at cost in healthcare, which is actually incredibly something that healthcare systems and centers have only recently begun doing, that it begins creating an awareness of that and can actually improve the outcome. So there's sort of some give and take in how big data can influence change. Then the next layer is actually empowering your grassroots teams to get at big data and answer questions that are relevant to them. So I work in the emergency department, and what if I could ask how many cases of influenza have we seen at Mayo Clinic in North Phoenix in the past week, and could pull that up right away. And that's the future state. We're not quite there at Mayo, but that's where you combine a data repository with the analytics, and then the ability to allow, particularly in my opinion, that your clinicians to query it in an easy fashion and then begin to pull up the data. And that's where we're headed.
When I hear about the size number, I mean, Mayo is big, right? Mayo is one of the great health institutions of all time, right? You're big, you're powerful, you own first base. What incentive do you have to change? I mean, when I've learned about organizational theory, big places like you become dinosaurs eventually, because you're not able to innovate, be nimble, and you have a kind of hostility, metaphorically, potentially, big institutions have a hostility to innovation, innovators, and people. So how do you fix that problem? Yeah. He and I were just chatting about this, so I'm not being totally offensive.
No, I actually welcome this conversation, because I think it is incumbent on all existing healthcare organizations, whether small clinics or huge medical centers like the Mayo Clinic and others, to ask ourselves, are we disruptors? And we exist.
Or are you castles with big walls?
Or are we castles with big walls? Are we maintaining the status quo? And if so, why? So we exist to take care of our patients. We are a not-for-profit, physician-led organization. We know that we can do better tomorrow than we do today. And there's several ways to do that. One is apply systems engineering to relentlessly study our systems, which we do inside of Mayo Clinic, and say, how do we do it better? How do we drive out waste? As you know, the IOM has estimated that 20 to 30% of the $3 trillion we spend on healthcare in the United States is waste. So let's do lean process mapping. Let's get systems engineers in. You heard from Victor Trastic earlier that we're applying this to our medical school education with our colleagues from ASU, because we want doctors who know how to measure and improve systems. That's one. But the other is, every organization, small, medium, or large, has disruptors in it. So let me just give you one quick example, Steve. All right, first, a quick show of hands. How many here have had a screening colonoscopy? I don't see quite enough hands, so a few of us are going to talk later. And thank you.
Next week, maybe.
So, all right, how many of you are looking forward to your next screening colonoscopy? No hands. I'm right there with you. So we have a scientist who about 15 years ago said, a gastroenterologist who said there's got to be a better way. And he began analyzing stool samples for nano traces of DNA that get sloughed by polyps and tumors. And fast forward to today, multiple trials later, published in the New England Journal of Medicine, we now have a technology that has been licensed to a medium-sized company that is called Cologuard, that detects 92% of colon cancers, the majority of polyps, and we've never in our country had a screening test for high intestinal or biliary cancer. We now do. So I would say, instead of just figuring out how do we drive down the cost of screening colonoscopy, how do we replace it with this new
Millions
test?
of people are watching online and want to know where to go.
And actually you can order it online and have it sent to your house. And so you don't even need a trip to a doctor.
What is the name of
So,
this?
Cologuard.
Cologuard,
Yeah.
okay.
So think about that as a disruptor. I mean, and instead of having endless conversations of how we're going to drive down the
Right.
cost of colonoscopy, why not just replace it with something better? Now, in full disclosure, there are situations, patients with known cancer, with known polyps, that we would recommend
Right.
actual screening endoscopy. But that's disruption.
Fascinating. You know, some of you may know Steve Case, and Steve was the founder, creator, co-founder, creator of America Online. He put, you know, all of us out on the digital space. He's got a great new book. And I had the privilege last summer of going to a bunch of Midwestern cities and going on what are called startup crawls. His theory, which he's going to make his next billion, I guess, is to find these startups in the Midwest that aren't in Silicon Valley or New York, that you can find really great, ingenious things happening in other parts, because he calls it the rise of the rest, that there are other places out there. Was a kind of fun. But when you go out to these business incubators in Milwaukee and Madison, Wisconsin, and you know, and different places in Iowa and others, I would say a majority of the innovators we're meeting in the startup spaces were in the health area, and that there was sort of this, you know, Disneyland, you know, kind of dark Disneyland-like castle, which was the medical center that employed massive employment.
Yes.
They would not share data, that they had all sorts of inefficiencies built in. And so most of these incubators survived by stealing talent from the hospital or the medical center,
Right.
and then doing something innovative and then growing it. But they saw the battle was with the health institution.
Right.
And I'm interested in whether that reads right to you.
No, it reads wrong. So again, why do our nation's great academic health centers exist? To take care of patients better tomorrow than they do today. So another piece that we integrated was an innovation center. So if we have a nurse or a doctor who has a good idea, instead of just thinking about it on their own for years, what if you have a place where they could walk in or email or call and say, I've got this idea, but I'm not sure how to test it or how to get it out there. And the motto, which is now become my leadership motto, is think big, start small, and move fast. So think about that disruptive change, but let's start with something doable, and that's how we embrace that in our innovation center.
You and I were talking a little bit about the value equation in healthcare, which is what a lot of this is about today.
Yeah.
It's about the cost curve, it's about
Yeah.
the patient in the process, literacy. How do you look at the cost equation or the value equation in healthcare today?
Yeah, Steve, this is critical, and I would suggest, and I know many of you in this room have backgrounds in healthcare and know this in spades, but it really is a critical equation as we think about it. Healthcare is not just about cost, which is often, and by the way, I'm a big believer in price transparency, so I think our patients should know how much their care costs. However, I think that they also should know what's the quality of care that they're signing up for, what's the outcome, what is the likelihood that they're going to die during a procedure in one medical center versus another. Because, I mean, again, let's just think of it personally. What's more important to us? Saving some money, which is important, or walking out of the hospital versus not? And all medical centers are not created equal. So the value equation is really safety, outcomes, quality outcomes. Did your wound get infected or not? Did you have to have 5 visits that you didn't expect to have? So think of it as outcomes with safety, service, and quality. So it includes service, which our colleague from ZocDoc really is focused on, but not just service, also outcomes. And then that should be measured with a denominator of cost over time. And let me just touch on the cost over time piece. So too often we think about healthcare as the actual cost per interaction, but think of it more as, if done right, then healthcare can cost more in an incident, but it might cost less because the patient doesn't have a wound infection and spend an extra week in the hospital, so it might cost less over a 6-month or a 12-month period. And that's really what we're focused on at Mayo Clinic, is how do we enhance the quality of care, but bring the cost of care over time down.
Now, is your particular center here just in Phoenix? So you're mainly doing the greater Phoenix area?
Well, so my particular role is as CEO of our Phoenix and Scottsdale operations. I also am a vice president of our organization nationally. So we're very integrated with our Minnesota and Florida operations.
So, you know, when you're seeing these health networks, you know, Blue Cross Blue Shield has these massive networks all over the country, and, you know, what you're doing in Mayo is there, but a lot of the country doesn't sit in neat, comfortable urban settings. And I'm just wondering, again, this whole question of when you are thinking about patients and the people that are out there, they may be out, you know, in the middle of nowhere.
Yeah.
They may be out in places that are so far off because it's what they can afford.
Yeah.
And I'm interested in this kind of gap and whether or not technology is helping us to reach people who wouldn't otherwise be serviced.
So a great example is telemedicine. And we've deployed telemedicine in rural Arizona for stroke patients. Telemedicine, by the way, is not new, and we did not invent it at the Mayo Clinic. I mean, it's been out there for over a decade. So what we realized is that 40% of Arizonans do not have access to emergent stroke care when they show up with a stroke. And I'll give you a quick vignette. Mark McNeary, and he's okay with us sharing his story, 69-year-old in rural Kingman, Arizona, which is up north towards Las Vegas, suddenly can't move his right side. He's having a stroke. He diagnoses it. He's got very slurred speech. His right arm and right leg are out. His wife throws him in the pickup truck. They drive 33 minutes to the Kingman Emergency Department. Pre-telestroke, he would have been completing his stroke while they called a helicopter to take him either to Phoenix or Las Vegas. It would have taken 3 hours, and the damage would have been done. Post-telestroke implementation, we have actually a video robot in the emergency room in Kingman that greets the patient with the nurse and the doctor. We can load the
I told you about
image
those
on.
robots.
Yeah, so we have trained the nurse to do a careful neurologic exam, which the robot watches while our stroke expert, who responds within a median time, after 5,000 of these consults, our median response time is 60 seconds. So it's not just about having a Skype-like link.
Right.
It's about all the technical details to do this right. So 24/7, within 1 minute, a Mayo stroke doctor is there. Mr. McNeary gets diagnosed with his stroke. Within 20 minutes, he gets the fibrinolytic or clot-busting medicine, and his movement comes back, and he doesn't need an emergent transfer anymore. So we found that this system lowers the cost of stroke care by about $1,400 per patient, creates better outcomes, and requires about 60% fewer transfers to centers like Mayo Clinics. And so this gets at how can we use technologies in ways that are smart to lower healthcare costs and actually create a higher level of care out in rural America.
So in 10 minutes, you've helped us with our colon and
Stroke.
telestrokes. What else do you have up your sleeve?
Well, let's talk about 2 other quick examples. One is the use of frozen sections. What am I talking about? Frozen sections, of course, here in the desert. But about 75 years ago, a pathologist at Mayo Clinic in Rochester, which has much colder winters, was sitting tissue that had been excised during cancer surgeries on his windowsill, and he realized you could freeze it and slice it, and he had the insight that one might be able to do this while the patient was still asleep on the operating table. Why is this important, even today? Because between 12, depending on the medical center, average of about 12 to 25% of, say, women who have a lumpectomy wake up, go home, or are in the hospital bed, and have to go back to surgery because there are not clear margins. So what if this 75-year-old technology, you freeze the tissue, you slice it, you look at it under a microscope while the patient's still asleep. We've been able to push down the reoperation rates from roughly nationally 25% to 4% at all of our Mayo Clinic hospitals. We then did an analysis and we said, well, what if this technique were deployed at every hospital in the country? It would save the nation or our providers, our insurers, about $90 million. And just think of the patient experience. I mean, what's it like to wake up from surgery just to find out that you don't have clear margins and you have to go back? So a better patient experience, more patient-focused, safer, because every time you put a patient under anesthesia, you risk a negative consequence, and lower cost. So that's another example of how we approach patient care at Mayo can drive down costs, but actually improve the experience and the quality.
Incredible. Let me go to the audience now, and questions as we get to the end of this. This is a fascinating guy. Anybody, comments, questions? Yes, right up in the front, our doctor. We got a microphone for you.
How are you? Yeah, welcome. Yeah.
Water Institute, but also a former Mayo Clinic physician. There's a wonderful website called EDGE, which is they're brilliant scientists in all disciplines. And one of the warnings that I saw come by was to be very careful with big data and the kind of multivariable regression analysis we do and make big mistakes.
Thank you.
Like vitamin E and cancer of the prostate, which I was involved in. It's not till you do a forward-looking clinical trial that you really get the benefit. Could you talk about that?
Yeah, thanks, Maria. Great to see you. Well, so Twain said it best. There's lies, there's damn lies, and there's statistics. And so absolutely, we have to be very careful. A common technique among clinical researchers, which I spent much of my career doing, is p-values. They look for what would you randomly expect 5% or less of the time to be abnormal. So, but if you look at 100 variables, then you would expect 5 of them, at least, to be statistically significant using a p-value. Then all of a sudden we get all excited and we start running around like we've made some major discovery because we think we have statistical significance. And so, not being a statistics expert, I will say that the clinician's view of making sure that we have, is this feasible? Does it make sense? And then do we have real experts behind the scene? And this is where our partnership with ASU has been so powerful. So at Mayo, we have this deep partnership and broad partnership with Arizona State University. The School of Biomedical Informatics is embedded on our clinical campus in Scottsdale. And what that does is it creates the ability to say, hey, are we getting this right? Are there better ways to analyze this data? So a healthy skepticism, just because someone says big data found this, you have to really look under the hood and be comfortable that the methods are correct and that there might be a need for corroborating studies. So
Terrific
great
question.
point.
Terrific question. Other questions? Yes, right up in front.
Oh, yes. Hi, Phil Schneider again from the College of Pharmacy. You mentioned Don Berwick, who's I enjoy listening to. His most recent presentation he gave at the National Quality Forum this past December, and it talks about the third era of healthcare. And one of the surprising things that he included in that, in his third era of healthcare, was less focus on metrics. His conclusion was we put so much emphasis on metrics that are other things that are really important right now that we need to be focusing on, including team-based care, et cetera.
Right.
So I'm wondering, since we've been talking a lot about metrics and big data, to what extent does that degrade our ability to focus on some of the other things that we need to do to actually provide care to patients?
Yeah,
Thank you. Great question.
Such a great question. Yeah, so having lived through the early era of metrics that were very process-oriented, there's a major concern because often innovation goes faster than the metrics. So we might have a metric that says every patient should, with heart failure should receive an ACE inhibitor, and then even big pharma has come out with better things than ACE inhibitors, but hospitals are scratching their heads going, do we give the better treatment or do we give the one that checks a box that gives us credit for giving high quality care? And that's really where the importance of being mission driven. You can never forget what you're there for, which in our case in medicine is serving the patient. So how do we serve the patient? And sometimes we have to do things that we know are good for an individual patient that don't help us, and in some instances even make you look bad in some nationally reported quality metrics. And that's really where having clinician leaders, so at Mayo Clinic.
That doesn't sound fun.
Yeah, you have to make those calls. You have to say, we're going to do what's right for the patient. We're going to be honest about our data and recognize that sometimes the way, particularly when it's a process-driven metric instead of an outcome, you're going to deviate to serve your patients best.
So just to wrap this up for a minute, I mean, what you just shared I think is a very valuable insight into some of the hard choices that you make as an institution around people's health. But you're also able to look at it at the macro level. And you know, I happen to sit in Washington, which plays around with a lot of this stuff at the macro level. What do you think needs to be fixed at the macro level so that the outcome you just talked about becomes a more regular thing and less painful process, less of a hard choice?
We're big proponents at Mayo Clinic of paying for value in healthcare. And you were asking earlier, you know, what are the mistakes of 10 years past?
Yeah.
And I would suggest one of them is our payment system. So every system is perfectly designed to create the outcomes that we observe. In our nation, we have a fragmented, overpriced, error-prone healthcare system. And so we have, perhaps by absenteeism, but we have allowed a system to evolve that has created that. We need to reward what we want in our healthcare system, which is excellent care at an affordable cost. And there are ways to do that, and actually we're working directly with CMS, but bundled payments can incent providers to have efficient costs with good outcomes. So the devil's in the details, and we could have another hour, I'm sure, talking about health policy and how to craft it in a way that encourages innovation, that encourages excellence in healthcare, and does not reward volume, which is our current system.
Are you from Arizona?
Not originally, but
Now, that
in 5 years.
Wyatt Decker name, that Wyatt, you know, Wyatt Earp, right? Isn't he from this state somewhere?
Tombstone. At
Yeah,
least he,
yeah,
had
so
his
I
shootout
just
here.
thought maybe you got a branch down there. So, ladies and gentlemen, Wyatt Decker, CEO of Mayo Clinic here in Arizona.
Thank you.
Thank you very much. Thank you.